So it's really great to be able to speak to you today a bit about the remote monitoring in care homes project that we're doing in North Central London using Whzan. So just to speak a little bit about the kind of the aim of this project and what we're wanting to do with it. So we're looking at introducing remote monitoring to over 100 care homes across 5 boroughs in North Central London. And I think really at the heart of this, it's around improving the quality of care that we provide to care home residents. So this covers people who are in nursing homes, but also residential care homes and learning disability homes as well. And what we know about that is looking at things like the Enhanced Health and Care Homes Framework. So this was an NHS England document which came out, which really looked at what are the learnings, what are the things that we know that improve the quality of care for those in care homes. There were some really key things that came out around kind of enhanced primary care support, the ability to work in kind of multidisciplinary teams, and really quite good use of data and IT and technology. And I think, doing remote monitoring, it really seems like it's a project that very much kind of hits a lot of those domains. So if I just speak a little bit about Whzan. So this is a picture of the Whzan blue box, and this has, a pulse oximeter in there, so you can get patients' oxygen levels, pulse. You can also check their blood pressure and their temperature, and that all kind of comes together on this tablet, which the care home staff kind of have in this box. And then there is a portal which can be accessed by clinicians, so for example, GPs, but we've also got lots of sort of nurses or community matrons who work with some of our care homes in North Central London. And they can look and have that patient data, which really kind of helps to inform decision making in terms of, when staff are worried about somebody being unwell. But it also allows for remote working, which we know in the pandemic has been really, really quite necessary. Our approach to kind of how we've looked to implement and embed it. So we very much wanted to work with the willing, and I think that's quite important whenever we are trying something new. So we looked to get expressions of interest from care homes who are really keen to get going from this, and also expressions of interest from GP practices, and really look to trying to kind of match those up and then take that forward from there to kind of see which homes we worked with. And I think in terms of stakeholder engagement, which is so important, we've taken sort of multiple strategies in terms of the team I'm working with. So we've got a team of nurse educators who work with the care homes, and myself and a whole project team. And I think it's been really key that the stakeholder engagement is ongoing, and whether that is written information, webinars, local forums, and really using a lot of the existing relationships that we already had in the system working with care homes to kind of, as the foundations for getting this going. What we found, and in terms of some of the improvement principles we've used, certainly we've done quite regular sort of PDSA cycles as we're implementing this. So even a simple thing like, how do we induct a care home in a GP practice? Constantly trying new ideas, often even on a weekly basis around, how we train people up. Do we do it in person? Do we do it remotely? Do we have a video for people? What feedback do we get? What do we learn from this to quite, keep improving on the process and fine tuning it the whole time? And I would say some of the key learnings from this have very much been around, I think, GP engagement's at the heart of it, and that needs to be a kind of an ongoing process to get people on board and on side. Certainly, it's perceived as most beneficial in care homes where this is adding something new. So particularly in our learning disability homes and in our residential care homes who weren't doing observations for patients before, this has really, really added something. Whereas for our nursing homes who were doing this sort of prior to now, it maybe adds something less so. So thinking about your environment and your setting. And I think there is a real opportunity with this, is what we've found, is that, you can add a lot more in terms of picking up other needs in the home and then actually taking those forward. So that might be training needs on how staff actually escalate when somebody's unwell. In terms of how we're evaluating this, so this is being led by the Health Innovation Network, and we're looking at a whole range of patient outcomes. So we've got a number listed here, particularly around things like falls, UTIs, minor head injuries, some of the really common things that people get sort of brought into hospital for. We're also going to be getting qualitative feedback from a range of clinicians, residents and staff. Where we're at the moment, so we've got 60 care homes who have implemented this and are using this. And we've had a range of really positive feedback, and I'll sort of leave you with this quote to look through, which comes from one of our carers working in a learning disability home, showing, how useful they found it, and it really improves staff confidence, and they're feeling that they're kind of right in their thinking and they can communicate with commissions. So thank you for your time, and I'll hand back to you, Breed.